Hey everyone, this is Ryan with Curbside to Bedside, and I'm here with Floyd and Dr. Ryan Stanton today, and we are going to discuss heat stroke and heat-related illnesses.
Yeah, guys, we're honored to have Dr. Ryan Stanton as our guest speaker today. He's got an extensive background in emergency medicine. He's an emergency room physician at Baptist Health in Lexington. He's also a spokesperson, one of the spokespeople for ACEPT, and he also does NASCAR coverage through AMR. Dr. Stanton, did that sum up your background?
Yeah, that's pretty much it. Basically, the quintessential emergency physician with ADHD who has a bunch of side hustles and et cetera. So, yeah, and that's it. What's nice is with that stuff with AMR and NASCAR, is we deal a lot in considerations with the heat-related issues. We recently have had several races where it got really hot. Interestingly, the hottest race, and I didn't work it, but the hottest race was Chicago. And so that's one of the things in consideration when discussing this topic is it's something that tends to impact, not necessarily where you would necessarily think it would impact closer to the equator, but a lot of times more in our northern areas. And so it's a big issue that we deal with and something that's had huge impact this year.
We're honored to have you on the show.
Thanks.
There's a lot of misinformation bandied about regarding heat stroke. Can you talk a little bit about exactly what a heat stroke is, how we define it, and how we differentiate that between heat stroke and heat exhaustion?
Well, a lot of it has to do with you get your little, everything's a spectrum in healthcare. So you have everything from the minor things such as heat cramps that you're going to get up to, then your middle level, which is going to be your heat exhaustion, and then your heat stroke is basically heat exhaustion plus temperature greater than 103 and altered mental status or confusion. And the issue is basically once you get to the heat stroke stage, exhaustion is what we are typically going to see. But the heat stroke is going to be something that's rare. That's not something we're going to see terribly often unless you're working in environments where that is you're going to concentrate that probability. But those are the ones that are a medical emergency. They are as emergent as a heart attack, as a stroke, because time is of the essence and the mortality is significantly elevated in those patients. So, a lot of times what we're going to see simply in typical work, EMS and emergency medicine is going to be those heat cramps, occasionally heat exhaustion. I've actually admitted 3 people in the last week with heat-related issues, coming in with bumps in their kidney function, rhabdomyolysis, of course, a lot of cramping, a lot of headache, a lot of nausea, a lot of dizziness. But the main thing that we see for admission is going to be the kidney function and muscle breakdown. But then, if you're going to be working, especially event medicine, so auto racing, such as what I do, Ryan military type applications, or both of you guys with outdoor wilderness type environments, you can concentrate those things. And I know we were just talking a few minutes ago, and you're going to mention, things like marathons and road races. I know a lot of them this time of year start moving over into either later in the evening or at least nighttime or very early in the morning because of the heat-related conditions. And I've also seen races that have been shortened, and I've seen races that have been completely canceled because of the heat, and understanding that, at some point you have to draw the line and say that the conditions right now are just too much to be dealt with.
So I know that about this time of year, every year, there's an infographic that circulates on social media that we refer to as the damn orange man.
Oh, yes. And shout out to David Pfeiffer for his crusade to try and kill the said infographic.
So, we want to contribute to the cause a little bit. So what is wrong with the damn orange man, and what is the actual definition of heat stroke?
The issue with a lot of things and with media is a lot of times the people who define these things are not healthcare trained, and so, with the heat stroke having those defined temperatures. Actually, so let's give an example. One thing that we see all the time that is the example similar to that is every year in emergency medicine, we do this roundabout with this whole topic of dry drowning. And it's just like the boogeyman for young mothers. They just think that this dry drowning monster is hiding out to take their children a week after going to the pool or getting in the shower or whatever it may be. And so you end up fighting because the problem with the way media and things is propagated now used to, if you had a bad piece of information out there, you just went to the news source, TV station, radio, whatever, and you offered your assistance and you corrected it. The problem is now everything has a life of its own online. And so it can propagate. And the issue is it's propagated by fear as well. So, when you look at most of these graphics, they're mainly designed to get clicks and to get repeats and to get retransmitted and rebroadcast. So you sometimes will push the limits of accuracy, whether purposefully or not, in order to get increased clicks and play. So the one that I saw that I thought was pretty funny recently was this. I think USA Today did it. Had this giant sun, and the sun had arms, and it had this giant thermometer that was peaked out, and the sun was holding this giant thermometer with it peaked out, and it honestly looked like a giant phallus that the sun was working over. And I thought it was. It got re-clicked, but it's one of those things where they just put these simple things to try to get people to understand. So you're taking information that the person who's putting it together doesn't necessarily understand because they're not medically or health trained, and then they're trying to translate that into what people are going to understand and engage with online. And then occasionally what you get are big orange men and sons having a heck of a time with a phallus.
Well, I've had a few EMT students over the past few weeks since we initially got together to discuss this topic. And every time I get a new student, I ask them, what is a heat stroke? How does it present? How do you define it? And how do you treat it? And they all give the same answer, and they give the same answer as what's been perpetuated in that infographic. So even as healthcare providers, they're not learning evidence-based medicine. And that's kind of what we want to do with this podcast, is to circle back around to the basics and present what the evidence says.
So the biggest bit of evidence is to remember that in the setting of exertional heat illness, so you have someone that's out and about, running around or doing what have you, if they're altered and they've been exerting themselves, you should go ahead and just empirically suspect heat stroke and start rapidly cooling them, be it with seizures or loss of consciousness or just generally not acting quite right. And one of the things to remember, and one of the biggest sticking points with the Orange Man infographic that everyone hates, is that anhydrosis, or the absence of sweating, is not a clinically significant sign to rule in or rule out heat stroke. About 50% of patients that have a clinical heat stroke will have sweating present, and the other 50% won't. And another thing to remember with that is environmental conditions and the local conditions of what that person was doing will influence whether or not there's moisture on their skin. So don't rely on that skin finding to initiate treatment.
And that is huge. And the thing is that when you're looking at infographics, if you are trained, so paramedic, EMT, physician, PA, nurse practitioner, nurse, whatever it may be, you shouldn't be having the infographic as the basis for your knowledge. I got it pulled up here just because I'd forgotten everything that was on it, just because honestly I don't look at infographics when it comes to getting my healthcare information. So the mindset being, the big orange man is for random Joe Schmo who's sitting on their couch, is going to go be doing some work outside, thinking about some things and worried about heat, just to lay that in. But what you need to think about from a medical professional standpoint is how and why. Understanding the how and why. So when I educate in medicine, I always educate on why things work. So I can define disease by understanding and defining physiology and knowing how the body works. So understanding what heat exhaustion and heat stroke are at the core is that overwhelming the body's natural abilities to self-regulate. And that's with heat and cold the same. Our body does an incredible job at self-regulation. But with heat-related and cold-related illness both, it's that overwhelming the body's ability to self-regulate. So what happens? Well, it doesn't mean that you're going to have the same symptoms. There's a lot of contributing factors. Why are you hot? Is it exertional? Is it non-exertional? Are you young? Are you old? What are the other contributing factors? Do you have hypertension and take blood pressure medicines? Do you have diabetes and thus have a higher risk of dehydration? Is it something where it's happening in a single episode? Or is it something where we see the majority of deaths throughout the United States, and that's prolonged exposure to heat, such as when you're in your house when the power gets shut off? And so it's not 110 degrees in the house. It may be 85 degrees in the house, but you're exposed to that for 4 or 5 days, or whatever it may be. So there's other things that can contribute. And if you stick to your mind to thinking that you have to check all of these boxes to qualify for it and say, oh, they're sweating, so it can't be this, so I'm okay, you're gonna miss people. Understanding that everybody's going to present a little bit different, but understanding how it happened and the contribution. But the biggest thing when it comes to heat-related illness is that index of suspicion, because so many things are determined before the patient gets to the emergency department. Whether somebody lives or dies or fully recovers is going to be determined by the folks that are on the front lines, especially when you're dealing with more rural settings. And so if you don't have that index of suspicion and start the treatment process, the likelihood of them deteriorating goes down. We're discussing it right now when it comes to sepsis management. Are we going to start antibiotics and draw cultures in the field? Started having these conversations with the stroke buggies. Trying to get these ambulances that are out there that are a giant waste of money with no information or efficacy. Good Lord, can you imagine taking a medication that has very little support, actual accurate support, and then saying we're going to spend millions of dollars to support this minimal evidence and have it available for 1 out of every 500 cases that we're going to make a run on. So we consider those things, and sometimes it's a good idea and sometimes it's a terrible idea. Stroke buggies, terrible idea. But when it comes to things like heat and cold, it's a great idea. Having protocols and things in place that are going to allow you to initiate that intervention can be significantly life-saving and, more importantly, recovery.
To build off what Dr. Stanton said, I was scrolling through Facebook the other day, and one of my friends shared it, and the International Institute for Race Medicine shared a news article from the Adirondack Daily Enterprise regarding a runner that unfortunately died during a mountain race. And the title that you can find there is Runner Dies of Heat Stroke from Whiteface Sky Race. And essentially what happened was they were running a course and the gentleman collapsed and he was recognized as being in cardiac arrest. CPR was initiated and the arriving EMS crew there gained an initial temperature, and it's unknown through what method, of about 104 degrees. And from the article, it does not sound like any sort of cooling measures or anything like that were taken, although that would be, that's speculative. But he was transported to the hospital, assuming fairly rapidly from the way the article is written, where his core temp was found to be 108 degrees. And unfortunately, he was unable to be resuscitated. And an interesting point from the management, at least as it's mentioned in the news article, is that the patient was placed in an ice bath at the ER, and CPR was actually continued while that active cooling measure was being done. And this goes to illustrate the point that you need to stay and treat these people on. It's a medical emergency like any other. But as you can see, what did they do in the hospital? They cooled them off and they did CPR. We can do the same thing. Most of these marathons and stuff like that have ice trough or horse troughs there. They can do the same treatment at the point of injury or at the point of illness versus waiting. And the way the article is written, it seems like the patient's temperature actually rose. And I don't know if that is necessarily the case clinically, but probably more, if I had to guess, a discrepancy between where the temperature was actually obtained on the patient. But there's no way of knowing actually how that happened. With a core temperature of 108, even if you are resuscitated, you're likely to have some pretty gnarly neurological issues ahead of you.
I don't think that a patient suffering a heat stroke should ever get to the hospital with a temperature of 108 degrees, because that means that we failed the patient. We did something wrong because we did not effectively cool them.
I agree, because the gold standard of treatment for heat stroke or something of that nature, regardless of whether or not the patient's in arrest or not, is active cooling. By active cooling, I mean cold water immersion therapy. And if you have the means, finding something, a body of water, a horse trough, to put them in, naturally protect their airway, but you actually physically place the patient in there and cool them down. And this is one of those, definitely a situation where running off to the hospital like a body snatcher is probably not the wisest choice in your clinical management of the patient.
A lot of things is going to be consideration of what you have. So I don't know about this one, but of course, like at the Boston Marathon, incredible medical staff and system set up there. They have experience, they have time, and, even when it's something significantly unexpected, they perform in an incredible fashion. But a friend of mine, Dr. Jonathan Fedek, who does ironcology, does a lot of triathlons and things like that, coming up in a few weeks, especially depending on when you guys put this out, is participating in the Norseman, which is what is considered the world's most difficult triathlon. 20,000 feet of vertical elevation change during the running aspect, I believe is what he told me. But there is no medical. Everything, you have to bring all your own support stuff. And so you may not have all of that stuff there. Of course, there the water is 45 degrees and you may be 80 degrees towards the water level, but once you get up high, you're going to be 45, 50 degrees, maybe even colder. But, a lot of that is that preparation and knowing with EMS is knowing your environment. And I think that's one of the biggest things each of us has to do is understanding the risks of your community and where you are and where you're practicing. And that may be a little bit of a challenge if you travel and do things, or you're outside your normal environment, but having somebody there that can explain risks and what you tend to see is going to be very significant. And then what kind of resources do you have? What kind of backup? What's your plan? So we do that with auto racing every single week. We establish what are the risks, what's the environment, what's our distribution plan, where are the hospitals, what are the capabilities of the hospitals. They even tour the hospitals to know what they have and what the setting is to get used to it. There's everything, a plan is made for the worst case scenario. And that's something that each of us needs to be able to do in our mind. And with an EMS agency, and some of you have, hundreds of miles of coverage, but most folks in EMS are going to have a pretty small. So Lexington is 250, a little bit less, 250 square miles of coverage area. So understanding what your environments are and what are things, and everybody can tell you this time of year we're going to see this is where we're going to see it. And knowing those types of things. So if you're fresh out, if you're just coming out of school, just getting your national registry or whatever you may be going for, knowing that's things to learn. You're still a learner, and we have to learn and understand and see what's being seen here and about, and being flexible. Because if not, then you're going to end up with a situation like this where somebody comes in, you don't initiate treatment in a timely fashion. The patient may or may not have actually had a elevation in temperature. Or, one thing that we're going to see, and I'm sure we'll talk about, is the fact that if you get an old guard paramedic or somebody who hasn't been on the front line in a while, and they're doing old stuff where you don't submerge patients because of that concern for shivering, and you didn't, so you're sitting there just trying to spray people down with water bottles and fans. Or you have the person who's trying to do a DPL and flush fluids through somebody's abdominal cavity, or dropping Foley catheters in, or irrigating their stomach. I mean, things like that, we evolve, we learn what works best. And, so in this case, getting somebody dunked in the water and dissipating that heat as quickly as possible is going to be what the patient needs.
I want to discuss pathophysiology really quick. We could go into great detail about the pathos surrounding heat stroke, but it's very complicated, and it would probably take a whole session to discuss the pathophysiology. But Rosen's breaks it down very elegantly, and they compared the body to a car's radiator. They refer to the heart as a pump, the blood as a coolant, and the thermostat as the central nervous system, or the hypothalamus, that helps regulate that temperature. And failure in any one of these systems can cause the body system to become unregulated. I think the basic gist of the patho behind heat stroke is that it's a sepsis-like syndrome. So for the body to dissipate heat, it shunts blood from the core, from the spleen, and from the kidneys, and it reintroduces it into the systemic circulation. So the vessels dilate, and that is actually the most effective form of heat transfer within the body.
But I want you to take a break right there. And as you're sitting there listening to this, I want you to think about what is going to trump, not our president, trump the body's natural ability to accomplish this self-regulation. And those are important considerations. Because with a growing baby boomer, with the graying of America that we have right now, we have this huge spike in patient populations where we purposefully dysregulate the system in order to accomplish a baseline goal, but makes it more difficult for compensation to stresses on that system. So you talk about dilation of the blood vessels or increasing flow, cardiac output measures. Somebody with blood pressure medications, they can't do that. Let's talk about diabetes. What are the two ways the human body can manage sugar, glucose within the body? Is you either process it or you piss it. That's the only two ways. So if you have too much sugar and you can't get it processed into the system, it's going through the urine, osmotic gradient, it's pulling fluids out, and you're going to end up dehydrated, decreasing that ability for evaporative cooling, for dilation of those blood vessels. All of these things are special considerations you have to make, and that's that next level of provider. That's that next level that you go to, which is that critical thinking of taking a situation and not only applying an algorithm in what you see in a book, but also then being able to think outside that box in terms of what is going to change that and what's going to build on that. When somebody comes to the hospital, 90 to 95% of that junk could be handled by almost anybody in that department. What the physician is there for is to think about some craziness outside the box, things that aren't presenting correctly, just putting different stuff together, more of a dynamic picture as opposed to a strict algorithm or a protocol, which tends to run a lot of healthcare, especially on the earlier stages of healthcare. One consideration for this is I teach for ATLS. An ATLS on the early stages is a very regimented, defined process. And you do this, you do this, you do this, you do that. But as you mature and you start to build, you start to understand the nuances and how to make the ATLS protocols and approach more effective and efficient for that patient by focusing on their needs based on mechanism and other contributing factors and risk factors. And so that's what we want you to do here. When we're defining the physiology of this, we want to think about what makes the physiology break, and it's not just heat and humidity.
I just think it's interesting that it mimics sepsis in the terms of the inflammatory response that you can see from this. I know one of the leading theories is that the mucosal permeability of the gut from the inflammatory mediators that are released systemically allow endotoxins from the gut to actually enter into circulation, leading to even more alteration in microcirculation and capillary blood flow, and more endothelial and tissue injury. And it kind of becomes a perpetuating cycle of awfulness if it's not intervened upon, which again, and I'm going to sound like a broken record the entire time, highlights the importance of early and aggressive treatment of these patients.
You mentioned the sepsis. And one of the biggest challenges of treating sepsis and why heat stroke is such a difficult thing to deal with is the body will often assist us, will help us to correct the problem. But with sepsis and with the extremes of temperature, especially heat stroke, you've lost that ability to regulate. And so the body will actually be working against you for a while until you can start to pull it back inside the lane and straighten it out. It's like a kid lost in the woods. As long as you're on the trail together, you can kind of get them going the right direction. But once that kid gets lost, they just start wandering, doing things that are dangerous and going to get them hurt.
That sounds like me on a normal day.
That sounds like that's most of us. But remember that when you start treatment, the reason we have to be aggressive with treatment is just having the patient sitting there on the cot is not going to bring them back into normal regulation and system function. We have to pull the person's physiology back into the realm of normal, not even normal, but back under the bell curve to where the body can start functioning normally again. Until you do that, it will work against itself. And we see this with autoimmune disorders. We see it with sepsis. We see it with all types of things where the body thinks it's doing something it needs to do, but in fact, it's working against and harming itself further. And so not only are we trying to deal with the acute medical issue, but also dealing with the fact that the patient's body is not working in your favor at the moment. And that in a situation like we've talked about with this case, if you don't intervene, the body is going to continue to do things abnormally. So when I educate on heat with media sources, one of the biggest things we talk about is remember, once somebody gets to the life-threatening part of this illness, they can no longer protect themselves. And so it's actually going to be the actions and intervention of somebody else that's going to save their life and not what they can do for themselves. If you can get yourself out of this situation and recognize that something bad is going on, then you're probably not at the heat stroke stage. But once they get to that more dangerous side, that's when it's going to require somebody from the outside recognizing, intervening, and taking action in order to protect that person.
I think this segues into our next talking point, which is about prevention and acclimation. There's a quote that I pulled from the Wilderness Medical Society guidelines that says, "An ounce of prevention is worth a pound of cure." And I know, Ryan, paramedic Ryan, you're very familiar with how to acclimate soldiers. I know a lot of times you don't have the opportunity to properly acclimate them to that environment, but how does one prevent a heat stroke, and how can you acclimate yourself to the environment?
So it becomes a question of what your practice pattern is and where you're at. It's hard for us in civilian, normal every third day type of EMS to really prevent heat strokes, but I'll back up and focus more on something that's more germane to me, which is from the military side of things. And to a degree, the wilderness and the competitive racing side of the house. But I'll speak specifically to military. And the biggest thing for me is you basically have to be their mom. You have to stay on your guys. One can think of acclimatization process as a heat vaccine. So basically what you're doing is you're not just going out and sitting out in the sun and just being like, well, it's kind of hot as shit. And then you gradually, quote unquote, get used to it, because that's actually not going to acclimatize you to anything. It's actually a highly regulated process, and the Army has a pretty detailed step-by-step way you actually go through it. The full process takes about 10 to 14 days. It can actually take a little bit longer depending on the environment you're in. But you have to start slow, exposing people to heat, and then gradually exposing them to increasing intervals or increasing intensity of activity performed at that temperature. So eventually your body will start to acclimatize through those repeated dosings, those controlled dosings of heat and exertion, and begin to tolerate more and more until you hit what's essentially a plateau point. And that plateau is when you optimize your performance. And when you optimize performance, the key thing that I have to tell my Joes is to eat all their meals. That way they get their electrolyte balances, or they get their electrolytes in shape, namely their sodium intake, and a controlled and sane approach to drinking water. And I say sane approach because there's still people in the military that I have to deal with routinely that think forced hydration is the way to go. And for anyone out there listening, pounding a shitload of water is not a great way to prevent a heat stroke, because it's not. It's actually probably going to make things a lot worse for you. But drinking and making sure they're intaking an adequate amount of water. Drinking to thirst. I drink small sips of water fairly regularly. Your body can really only process about a quart of free water an hour. So drinking any more than that is kind of useless and just serves to basically make you functionally hyponatremic, which is only going to make things worse if you actually find yourself get into a bind if you start to overexert yourself. For my Joes, just being very cognizant and actually going out and educating them and educating their leadership. I try to make my life as easy as possible and use my guys as a force multiplier. So they've had education on what to look for and what to do and how to initiate active cooling measures in the field, even if I'm not there. Granted, they'll come and get me. They will let me know. Because they're very loud, but they know how to treat, and they're confident in their ability to treat because the treatment is simple. Your buddy's not acting normal. It's hot as shit outside. We're wearing body armor and mob gear and out here running around. They're going to strip him down to being bare ass naked. They're going to grab the ice sheets and they're going to cool him until the medic gets there. They tend to take care of it themselves. The hardest part with the Joes is actually making sure it's prevented in the first place. And after watching, one heat casualty, they all kind of get the point. That, and they're all deathly afraid of the silver bullet, as it's called, or my rectal temperature probe. No one wants the silver bullet. So, and they know if they come in with a heat-related emergency or a heat-related issue, they're probably going to get the silver bullet. So that also serves as its own deterrent. But really, it's very simple. It comes down to acclimatization, proper nutrition, and a pretty decent approach to your water intake.
I just think the acclimatization process is very interesting. And, I was reading earlier that it actually helps your body to start sweating earlier and helps the body to sweat larger amounts. And that's kind of part of how it helps you acclimate. I also found it interesting that, going back to what you were saying, the overhydration doesn't really change your heat tolerance at all. And actually, even moderate caffeine intake doesn't affect your heat tolerance either.
No. Now, that can vary from person to person. I know if I, have a few cups of coffee in the morning and then I go out and start sweating my balls off on a fire scene or something like that, I'm not going to feel that great versus if I had just been drinking water that morning. But that's me. And I also don't eat breakfast, which goes back to the whole nutrition thing.
We'll say moderate caffeine intake plus hydration.
Yeah.
Well, the issue is people think that hydration is the fix. They think that the hydration itself is the cooling. No, that is just to support the sweating and evaporative aspect, making sure that you're hydrated. And that's the issue that we've seen is all three that I've admitted have said, I stayed well hydrated. I drank plenty of fluids, but that's a consideration that is not a fix. Dousing yourself or drinking water nonstop, running through the desert is not going to prevent heat-related illness. It may decrease or delay it a little bit by staying adequately hydrated and having all of the supporting tools for the physiology there, but it's not a preventive. It does, that's things to understand. And, you talked about it last time. I actually talked to one of our medics, who's military as well, about the outside activities and, all of that stuff and the restrictions and things like that, especially during that acclimation period. And there's things that you have to understand that, just drinking water and just drinking fluids, no matter what types they are, is not going to prevent this from happening. If it was, then we wouldn't need support teams there at marathons.
And one of the other main points that I actually neglected to mention is on the aspect of prevention is knowing each other. Floyd and I and Dr. Stanton, we're all involved or employed by a fire department. And one of the hardest things, and probably one of the things that will serve you the best, is knowing when you have to take a knee or stop. And firefighters are incredibly stubborn creatures that do not like to listen, and they do not like to stop working, especially on a fire scene or something like that.
Because you get made fun of if you say, I need a rehab.
This is true, and it's probably not the right approach. But the thing with, it goes with the military as well. So, sometimes operational constraints don't allow you to take a break, but there's some things you can do to mitigate. But if you're getting into a position where I am way too hot, or you're starting to notice that in a peer, stopping them before they go and cross that line and getting them back down and getting them cooled off, that is a lot better than trying to rehabilitate someone or treat someone that's had an active heat stroke. I'd much rather let someone sit in my aid station for 4 or 5 hours and cool down after a moderate case of heat exhaustion rather than have to send them out completely after a heat stroke.
And if you have a heat stroke, then you're going to hinder the overall mission for months to come, right? Because
it's bad news bears.
Because once you have a heat stroke, then you're essentially flagged, right?
Yes. So whenever we have an environmental casualty in the military, the typical, it's not necessarily protocolized or anything like that, but you'll find that they are marked either with heat casualties are marked with either a red patch on the uniform or more commonly a red bead that's either hung from the lapel during field exercises or in one of their boot laces. Alternatively, cold injuries have a blue bead typically. And then if you're just a nightmare of thermoregulation, you can have a red and a blue bead because for whatever reason, you just don't learn. So it's not necessarily a luxury that we have out in the field with us on the ambulance, but there is a method. So everyone's familiar with the heat index, which is a function of the temperature and the humidity. That's typically what you get on your weather app and stuff like that. But in the military, and I'm sure they use it with Dr. Stanton's NASCAR stuff and for wilderness races and stuff like that, you typically will find what's called a wet bulb globe temperature reading device. And it's just a type of temperature estimate that factors in all of the components of what makes it so damn miserable outside when it's hot. So the actual apparent temperature, humidity, wind speed, and visible and infrared radiation from sunlight. So it's basically a composite of all of the things that go into making it hot outside. And we in the military use that to adjust our what are called work-rest cycles. And that also helps us prevent more heat injuries. So there's a categorical system of 1 through 5 of heat categories that are based on the wet bulb temperature. And we can, depending on the type of work you're doing, restrict your work. So if it's a black flag day and you're in body armor doing strenuous work, in a training environment, you might find yourself doing 10 minutes of work and 50 minutes of rest, ideally. Is that ever actually followed? No. Mostly because we wouldn't get anything done if we follow that to the letter. So it becomes more a question of watch your guys, be sane, and keep a really close eye on the wet bulb so we don't do anything stupid. But it also, we use the wet bulb as part of operational planning too, because we might defer some aspects of a mission or an operation if we can, if it's going to be just ridiculously hot and just that's going to have that much of an impact on our guys.
It really is more of an accurate consideration. So we like the heat index, for people with temperature based in the shade and things like that. But, with more realistic, when you're dealing with heat-related illnesses, a lot of times it is going to be really the contributing factors of all of the environmental elements. I mean, you don't run a marathon just in the shade of trees. You got to deal with all of the environmental elements. And with the military, you aren't just fighting or more training or drilling in the shade of trees. You're dealing in all types of environments. So being able to understand that, it's important. But really, more importantly, is understanding the person. If you get somebody who has been sitting in their basement playing Dungeons and Dragons for 35 years and put them out there to train with you guys in the military versus somebody who has been out there training now for weeks on end, your response is going to be very different. Next time you get a chance, and I'm sure almost everybody right now has got their cities, doing a lot of paving and stuff from where we had this nasty winter and there's potholes everywhere. You've got folks out there working on fresh asphalt with long pants, with a sweatshirt, with a hooded sweatshirt to protect themselves from the sun, and they have no issues whatsoever. And yet you have other folks who are out there training for their couch to 5K in their shorty shorts and tight shirt, and they're falling out all over the place. I mean, a lot of it, understanding the person is going to significantly impact their risk as well. I was just amazed this guy was working, and I mean, it looked like it would have been what I would have worn when it was
There's no
30
thing to
degrees. No, it's nothing. It's no consideration. It's every single day, but they know how to manage it, and their body is accustomed to it.
You want to talk about field treatment real quick?
I was about to ask you the same question.
Well, I can do it. So it's focused on rapid reversal. So as we know, the morbidity and mortality of severe heat illness or heat stroke is directly related to the intensity and duration of the event. So the quicker you get ahead of this 8-ball, the better your patient will do, most likely. So the gold standard of treatment is immersion therapy in cold water. If you don't have cold water, that's fine. Just immersion therapy, because that water is still probably not going to be as hot as your core temperature is. And therefore, you'll be able to offload some of that heat. Naturally, you want to manage your ABCs. And if you do immersion therapy, use your head and protect their airway.
So immersion therapy, for people who don't know, ideally you want a ice bath, basically, right?
Yeah, it's literally just a trough full of ice, a shallow trough full of ice. And they're typically a little bit short. That way people can't
drown themselves.
Basically drown themselves. You see it a lot at football fields. Athletic trainers are really big into them because they help the athletes cool down a lot.
And this has become like the standard of care. And historically, and when I went through paramedic school, if anyone told me that we're going to be immersing people in ice water, I would have laughed at them and be like, "You'll kill them. You'll put them in a shock or something like that." But now it's the standard.
Which is, you're not going to send anyone into shock. I know that's something that's kind of been perpetuated, at least in pre-hospital education. Someone that is a heat casualty and putting them into cold water immersion therapy, you're not going to shock them. They are already essentially in a state of shock. So you're just working toward, now if you take a normal person and dump them into an ice cold bath, yeah, you may get a response out of that. But in working backwards from there, the other thing that we use in the military is called ice sheets, and it's basically just an igloo cooler or a Gatorade cooler that has literally just ice and wet sheets in them. And it's a little bit more portable than a horse trough because I can actually take that cooler places. I can put it in the back of a truck. I can put it on, for my day job, I can put it on the back of a fire engine or something like that and have it at the ready. And it's not as great as immersion therapy, but it's a close second. So I can take those wet sheets, those cold wet sheets out, place them on a patient, and then rotate them until that patient is appropriately cooled. And the other thing, just, if you open up the back doors of your ambulance and you're like, I don't know how I would treat a heat casualty with all of the stuff back here. Most of us work in places that have a fire department. Some of us even work for fire departments. Fire departments are really cool in the fact that they have these gigantic trucks that are full of water. And their one goal in life is to get that water off the truck in a spectacular fashion. Don't be afraid to utilize the resources at your disposal. If you need to douse someone to cool them off in the field, do it. If you need to, I know most of us don't like, carrying patients through their residence any more than we absolutely have to. But if you have someone who's elderly and having a passive or classic heat stroke, don't feel bad if you start to run their bath or something like that, because getting them in that water is going to help. And you need to treat them on site before you start trying to boogie out of there.
Yeah, I mean, know your resources, right? Know how to utilize those resources. If you have a tarp, there's this method referred to as the taco method, where you kind of lay someone on a tarp, have a few people on each side, elevate the head a little bit, and just pour ice water into that tarp. And to me, that's a very practical way of cooling someone. If you're at like a sporting event, you have a tarp, and then you have a bunch of tubs of ice water for people to drink. Just use that to cool them. There are other methods. There are many different methods of cooling people, but the way that we traditionally thought of cooling someone using ice packs or IV fluid is just not effective. Ice packs in the groin, axilla, the neck, the groin, it's just not effective to cool someone that way. Now, if you have enough ice packs, it's much more effective to cover the entire body and ice packs if you have to do this. But I want to quote some numbers real quick that I pulled from the Wilderness Medical Society, is that immersion takes advantage of water's high thermal conductivity, which is 24 times greater than air. Ice water cooling is 2 times as rapid to reduce core temperature as spraying water all over the body. So I think that's kind of why ice water immersion has become the gold standard. And the most common rebuttal is probably the Curie response, which is shivering. Shivering can produce a little bit of heat. 0.02 degrees Celsius a minute or something like that, which is a very marginal amount if you compare that to how fast you're cooling that person using ice water immersion.
I think, and Dr. Stanton, feel free to correct me, I think the Curie response is more clinically relevant in cases of like anesthesia-associated malignant hyperthermia or something like metabolic or something of that nature. Yeah, if you got something where
you don't want shivering. I like when kids come in with fever, a lot of times I'll throw them into something, and they'll produce shivering. And I'm not a huge fan of that. For one, the fever is a normal, healthy response with reaction to infection. But when it comes to heat-related illness, we're trying to drop that down. You're going to overwhelm that system. So the amount in versus the amount out is going to be significantly different. And for those that are young enough out there, what you're talking about with that transfer of energy is the specific heat of a substance. Specific heat is the amount of energy required to raise or lower the temperature of the substance a certain amount. And so we always would do that. That's how calories are actually determined. That's how you calculate calories, is the amount of energy that's required to break that down. And so, with this, you're right. The air, the specific heat of air is much lower than it is with water. Water can pull so much more energy off. And that's one of the issues we used to have with swimming, is if the pool was too hot. So most of us like to swim in a pool that's in the mid 80s, pushing nearly 90 degrees. But if you're a competitive swimmer, You want it down in the 70s, if not cooler, because if it's too warm, then that water prevents that dissipation of heat and you build up. And we would get heat-related issues all the time just from swimming in water that was designed for old people to do jazzercise in and not for, pools that were designed for competitive swimming. So if you go to a competitive swimming pool, it's going to be much more colder than you are comfortable with. There is a point where it gets too cold and it's no fun anymore. But, always the first time we would jump in at a pool, it was the right temperature. You'd always get that response where you come up really cold, but as you swim, it would get you a lot more distance. And so that's why that water, the difference is when you're talking about, spraying somebody down with water is the volume of water of which you've got to raise that temperature. Does not, if you have a little bit of water with the volume of water inside your body and heated substance, that's nothing if you're just spraying. But if you submersion, you have to have more ability to remove heat than you have heat that's already built up in the system, in a system that is continuing to work and produce heat and energy. Our bodies naturally are producing heat 24 hours a day, 7 days a week. And so if we don't have something that can overwhelm that ability with the overregulation associated with heat-related illness, then we're not going to catch up. Specific heat, high school chemistry.
Thermodynamics are hard.
Too complicated for me. Let's move on.
I like pictures.
Here's what I want to know.
I know one. I've got a picture with a big orange yellow man on it.
Not that damn thing again.
We know we're done with him. He's dead. Okay. So are we going to get a rectal temperature?
Yes.
Why?
Unless you're rocking an esophageal probe and somehow have a patient that's willing to let you do that, that's your best shot, because cutaneous readings of temperature are notoriously inaccurate. So your temporal or your tympanic measurement, they're just going to kind of spitball it. Oral's great for routine. If you are basing a clinical diagnosis or managing treatment due to primarily a temperature dysregulation, you need to get to as close to the core of the body as you can. And I don't mean that like just spearing them and trying to figure it out, but the rectal temp is going to be the way to go, because an axillary temperature is not going to be reflective of the true core temperature of a patient, and necessarily neither is an oral temperature. If you have the equipment to properly take a rectal temperature, you should do it, especially in the heat-related emergencies. We initiate treatment empirically. Don't wait for a rectal temperature necessarily to start treatment. But at some point during and following your treatment, you should obtain a rectal temperature, to make sure that, hey, maybe it wasn't heat stroke. Maybe their core temperature is fine and they suddenly got altered. But you're out in the wood, and it's hyponatremia, or it's hypoglycemia or something like that. The risks of not initiating rapid treatment for someone who presents like heat stroke are far greater than the risk posed by treating them as such and then ultimately not having the condition. And that's where your rectal temp comes into play. It also helps you kind of get a good eye on when you should probably stop and then reevaluate what you've done. But that's my personal practice, and I think that's the recommendation of a lot of people that manage it routinely.
Yeah, I mean, you can get into a lot of clinical misadventure if you don't properly utilize your diagnostic tools.
Now, the challenge is going to be a lot of times once you get to the extremes of temperatures, a lot of your instruments aren't going to be accurate. I mean, some aren't going to read much above 104. So a lot of it depends on what you're using. But unfortunately, a lot of times, we've gone for the easy button, is you got folks that are going to show up with their thermal forehead thermometer and swipe it across the forehead and say, oh, they're only 94.2. They're fine. Instead of getting that, it still blows a lot of times away in the emergency department when you say, in the pediatric patient, I want a rectal temperature. Well, they can hold it in their mouth. That's fine. That's great, good for them. But I need one in the butt too, because you have to have that accuracy. There's so many things that can throw it off, and it's important to have that core temperature, and then also to continue to monitor, because that's one of the things we found with the increased morbidity and mortality that we see occasionally with that what used to be called therapeutic cooling, was the fact that we were getting too aggressive and diving people too low and causing just the same and another whole set of issues when we overcooled patients. And what you were talking about with, marathon runners, you're going to have that a lot of times. It's going to be more of a hyponatremia issue, not necessarily a thermal issue. And so make sure that you're chasing the right demon, because if you chase the wrong one, you may allow the other one to wreak havoc. And so making sure you do that right thing and get that temperature. So that is going to be key. Under the armpit, in the mouth, across the forehead, that's laziness. That's fine if you really don't care. I don't mind a forehead thermometer, and I don't mind an oral thermometer when I don't care about the temperature. I mean, we have to get those because that's the rule, especially in emergency medicine, but EMS as well. You have to get the temperature, and if you don't care, I really don't care about how accurate it is. But when it's something that's going to determine the diagnosis and treatment plan, that's when you have to make sure that the information you're getting is actually accurate. 'Cause I know you guys both often will talk about things with treating numbers and the accuracy. And to me, it's numbers are important if the numbers are accurate. Mm-hmm. Bad numbers can be more harmful than they are helpful. And so making sure that you have the right numbers is going to be key to driving your treatment plan.
Dr. Stanton, how can folks get a hold of you? Are you on Twitter, Facebook?
Yeah, I'm on the Twitter and on the face page. Stanton MD Stanton MD Everyday Medicine on Facebook. Twitter is at Everyday Med. We've got podcasts as well at ACEP Frontline, which is a weekly podcast through the American College of Emergency Physicians. That's available on iTunes, SoundCloud as well. So, check that stuff out. We got other information. Goal to be, to make sure that you're on that cutting edge, that front edge, that you continue to learn. Because remember, even though you finished school and you have a degree, and you've passed your boards and are certified to do whatever, does not mean, one, that you know it all, and two, does not mean that the information and education and evidence are not changing. So that's our goal, is to make sure that you have the most up-to-date information and continue to learn, because, whether you like it or not, if you're doing healthcare, you joined a profession with lifelong learning. And so until the day when you retire, at which point you can sit back, relax, and drink iced tea all day without having to study anything, the only way you're going to do your patients proper service is by constantly evolving your craft and learning and driving to learn more based on the evidence that's available.
So that was our closing statement. Let us know if you have any questions. You can reach out to Dr. Stanton personally. He's a very approachable guy. Or you can route it through us. Either way, thanks for listening. And that's all for now. Bye.